My name is Matt S, and today, along with my group of Luke, Sonic, Beau, and Matt X, we're going to be going through an MRI of a shoulder case assignment. So, in terms of our agenda, we're going to go through multiple components such as the case presentation, the rationale for the test, indications/contraindications for the test, accuracy of the test, key elements of test results, other relevant tests, and patient education. And throughout our presentation, we're going to go through multiple objectives, which includes presenting the example case study, discussing the rationale behind why the patient received an MRI, the indications and contraindications for an MRI, the results of the test and how it impacts our clinical care, and most importantly, conveying why imaging is useful and important to us as PTs.
So now moving on to the case presentation. So this patient was a 35-year-old female who presented to physical therapy with chief complaints of left shoulder pain and stiffness, along with significantly reduced range of motion, mainly impacting her ability to reach overhead, hold her children who are aged 5 and 9, perform household chores, specifically those involving lots of reaching, as well as sleeping comfortably on the affected side. There was no fall or mechanism of injury for this pain, and it was completely insidious. She also had no pain radiating down the arm. Over the course of the first 2 months of treatment, treatment focused on regaining that range of motion and preventing pain, but there was little improvement seen over the entirety of treatment. In terms of her objective measures, at the end of that 2 months of treatment, she had an abducted shoulder external rotation range of motion of around 10 degrees with increased stiffness and pain. Shoulder flexion was around 100 along with shoulder abduction, both with stiffness and pain. And she had an abducted internal rotation range of motion value of around 20 degrees with stiffness and pain. And she was testing positive for lots of the rotator cuff special tests, such as the empty can, the bear hug, and the dropping sign. At this time, our differential diagnostic thoughts were that it was either going to be rotator cuff pathology or adhesive capsulitis. And then a little bit lower on the list, we also were still factoring in things like subacromial impingement or potentially a labral pathology.
Initial treatment. Clinical decision-making. The CI suspected adhesive capsulitis early on, but therapy was initiated for rotator cuff pathology per the MD referral. Initially, this patient was treated as though they had a rotator cuff injury. Treatment was goal-based and aimed at pain modulation, retaining range of motion, strengthening of area, and regaining functionality. A typical treatment session composed of manual therapy, joint mobilization, barring excessive pain, active range of motion exercise for shoulder flexion, abduction, external rotation, and exercise for muscular endurance at the rotator cuff as tolerated. Over the course of treatments, patient did not really improve, however, symptoms did not significantly worsen. So what is our rationale for image testing? After 6 weeks of minimal improvement, the patient returned to the MD for further evaluation. The MRI was completed to differentiate between the initial referral for rotator cuff pathology and the CI suspected adhesive capsulitis diagnosis. The patient's symptoms align with the diagnostic criteria of adhesive capsulitis, despite being below the typical age threshold of 40 years old as suggested by the APTA, CPG on adhesive capsulitis. Therefore, MRI imaging would help to confirm the symptom-supported differential diagnosis of adhesive capsulitis. What do rotator cuff pathology and adhesive capsulitis typically look like on MRI? The rotator cuff pathology typically presents with torn or degenerative tendon fibers, but a preserved capsule of the GH. Adhesive capsulitis typically presents with axillary capsular thickening, hyperintensity enhancement, or fat obliteration of the rotator cuff interval, the RI enhancement, RI joint capsule thickening, or coracohumeral ligament thickening.
So what are the indication and contraindication for MRI imaging? For indication, MRI is really useful for soft tissue imaging because of the mechanism behind an MRI uses water content, so the soft tissue can have better details compared to other plain field radiography. And some contraindications include metallic substances on the patient because it uses a lot of magnetic field in order to generate the image. So anything that's metal on the patient should be removed. In terms of other considerations, pregnancy is generally accepted, but if there's any contrast that's required, it's generally avoided if patient wants to do MRI. And the second consideration is claustrophobia, which can be very important for MRI because of the device. Now let's talk about the diagnosis statistics of a MRI in terms of adhesive capsulitis. So for AC, an MRI is really useful because, as I mentioned previous slide, it's very useful for the details of soft tissue. And this study presented on the slide shows that when examining 6 classical features that is found in AC, there's a really high specificity in terms of discovering the key findings when we find an AC. And it's key to notice that there's other tests such as the blood test and other tests that may be helpful to determine the predisposed condition of the patient. But in terms of directly diagnosing a AC, MRI is still the best option for us.
So here we have the typical presentations of the shoulder versus in adhesive capsulitis. So the following below are two type 2 MRIs showing coronal sections of the glenohumeral joint and the humeral head. The image on the left is what the typical presentation looks like, and the image on the right shows a shoulder with adhesive capsulitis. So in general, a patient with AC will have may have MRI findings of a thickened joint capsule, capsular edema as seen by the white fluid in the joint, or coracohumeral ligament thickening. So for our case specifically, here are some key elements of the results. So for our image findings themselves, the MRI confirmed adhesive capsulitis of the left shoulder, which was seen via joint capsule thickening in the inferior and posterior aspects of the glenohumeral joint. The X-ray also revealed calcific tendinopathy at rotator cuff insertion sites. So for our actual experience, the clinical experience ended before we were able to conduct a follow-up session with the patient following her imaging. So from now on, the following slides are a hypothetical simulation of how we would approach the case moving forward if we did have more time with her. So here is the effect of our diagnostic testing on our clinical reasoning and approach for our patient case. So the current APTA CPG, as shown by the little snapshot on the right side of the PowerPoint, does not currently have any evidence-based standardized selective tissue test as seen in other shoulder pathologies to diagnose AC. So in the CPG, clinicians are instead recommended to rely on symptoms and patient characteristics to determine the likelihood of whether or not they have an adhesive capsulitis. So having the MRI confirmation that the patient's impairments were due to adhesive capsulitis as opposed to something else like a rotator cuff tendinopathy was important in setting our prognosis and expectancies for the patient recovery. Since we took an impairment-focused approach with our patient initially, targeting pain modulation and range of motion, our initial intervention plan was not actually that contraindicated or that different to what we would have done if we had known it was AC all along. And there are likely still of benefit to the patient given that they actually did have AC as opposed to what our initial diagnosis or our initial hypothesis was. Instead, the main benefit of having this confirmed AC diagnosis is that it clarifies a timeline for us and the patient and explains why our interventions were not really yielding improvements. Since we had only seen the patient for 6 to 8 weeks, if the patient did have a rotator cuff injury, we would have expected to see improvements by then. But now knowing that she does have AC, it kind of tempers our expectations and realizes that we're not necessarily on the wrong track.
And now, patient education. When informing the patient about the diagnosis, it is important to convey patient-friendly language. This includes acknowledging the patient's frustrations or feelings, avoiding the use of danger words and jargon, and communicating long-term goals that address their concerns as well as their goals. In doing so, this helps build the foundation of a healthy, patient-friendly relationship. Now on the slide is an example of good patient education. I understand that this situation with your shoulder has been frustrating, but I'm glad to let you know that this MRI test has helped us identify what's going on. The MRI helped us to rule out rotator cuff damage as the main cause and confirm the diagnosis of what is called adhesive capsulitis, otherwise known as frozen shoulder. With this, the tissue in your shoulder joint thickens and becomes stiff over time. Typically, your shoulder has enough motion to allow you to move your arm around, but when that tissue becomes stiff, it can limit your mobility. The exact cause is not fully understood, but the good news is that over time it will heal on its own. That being said, therapy can help to retain as much motion and strength as possible to keep you functioning throughout the process. Adhesive capsulitis has 3 stages: freezing, frozen, and thawing. In the freezing stage, your shoulder is typically the most painful and you start to lose motion. In the frozen stage, the pain subsides, but you have much more limited motion. Finally, in the thawing stage, you are still in less pain as you begin to regain that shoulder motion. In most cases, this diagnosis will run through its course within 2 years, but this timeline can vary. It'll take some time, but together we can work together, getting you back on track and doing all the activities you'd like to return to. Moving forward, knowing that the diagnosis is adhesive capsulitis, exercises can remain the same, specifically with a goal of pain modulation and retaining range of motion. Exercises should also be functional and goal-based, as the patient is motivated to be able to carry and pick up her 4-year-old daughter. As the patient becomes more comfortable with our home exercise program and exercises in the clinic, we can decrease the amount of visits in the clinic and the recovery can become a more independent process as long as the patient remains motivated. Attach our references and thank you for watching.